Sorry, get that there. As many of you know, the seminar is held on the 2nd and 4th Mondays from September through June, and we include speakers with work focused on child health from both UCSF as well as guest speakers. Please let me know via email if you're interested in speaking or would like to suggest a speaker. Looking ahead to our next speaker, we'll be welcoming Dr. Jackie Grutt-Phelan from the Division of Pediatric Emergency Medicine and the Department of Emergency Medicine on April 10th. We're still virtual and using Zoom, and we'll ask that everyone stay muted unless you have a question, and we will open it up at the end for questions as well. Today, we're welcoming Dr. Shylaja Srinivasan, an assistant professor of pediatrics in the Division of Pediatric Endocrinology. Shy's research is in the area of prediabetes and type 2 diabetes in youth, focusing on the pathophysiology and therapeutic strategies in this population, with investigation of genetic variation and determinants of medication response. Her research is funded by NIDDK. The title of her talk today, as you can see, is Genetic Basis of Type 2 Diabetes and Related Traits in Youth. Thanks again for joining us, Shy.
Thank you, Roberta, for the introduction and for the opportunity to present today. Good afternoon, everyone. Thank you for being here. So as Roberta mentioned, today I will be sharing my work on the genetics of type 2 diabetes and related traits in youth. I have no relevant disclosures. And here's an overview of my talk. So I'll divide my talk into 3 parts. The first part will be to lay some background on the growing problem of type 2 diabetes in pediatric populations. I'll spend a large part of my talk discussing some work on the genetics of type 2 diabetes in youth, and then I will also briefly discuss some work related to metformin response in youth with type 2 diabetes. So starting off with the first part and the growing problem of type 2 diabetes in youth. So type 2 diabetes is unfortunately no longer a disease of just adults. I think even 10 to 15 years ago, when we said type 2 diabetes, it was usually synonymous with adult onset form of the disease. But unfortunately, that is no longer the case. So here I show data from the Search for Diabetes in Youth study, which is a population-based observational study that reports epidemiological data for both type 1 and type 2 diabetes. So what you're seeing here is a trend in incidence of type 2 diabetes between 2004 to 2012. And it's very easy to see that there's been a rise in the incidence of type 2 diabetes and that it's more dramatic in youth of color. So Search reported that the incidence of type 2 diabetes increased by 5% per year between the years 2002 to 2012. And the prevalence of diabetes doubled from 2001 to 2017 with a disproportionate burden on youth of color. And I'd like to contrast this with data from Search on type 1 diabetes, where you can see that there has been an increase in the incidence of type 1 diabetes as well, but it's definitely more subtle and doesn't have the same racial and ethnic distribution that type 2 diabetes has. So across all age groups, individuals of color are at a disproportionate burden for type 2 diabetes, but this risk is especially true and compounded in pediatric populations. And the COVID-19 pandemic only made things worse. So this is a multi-center study of 24 sites in the United States, including UCSF, and has data both from Children's Oakland and San Francisco sites. And we found that new cases of type 2 diabetes increased by 77.2% in 2020 to 2021 compared to the mean of the previous 2 years. So the black line in this figure depicts the onset of the COVID-19 pandemic, and you can see that there's an increase in the frequency, and the blue parts of the bars indicate the frequency of cases of metabolic decompensation. So this would be diabetic ketoacidosis, DKA, or hyperosmolar hyperglycemic state. And the frequency of these conditions also increased with the onset of the COVID-19 pandemic. And unfortunately, future projections look like things are only going to get worse. So again, data from Search indicate that there is likely to be at least a 4-fold increase in the number of pediatric type 2 diabetes cases by the year 2050. So we definitely have a significant and growing problem on our hands. And the thing about youth onset type 2 diabetes is that it is a very aggressive disease with increased mortality compared to youth with type 1 diabetes, as well as adults with type 2 diabetes. So this is data from an Australian registry cohort where they looked at the mortality data for individuals with type 2 diabetes diagnosed between the ages of 15 to 30 and compared this with age-matched individuals with type 1 diabetes. And you can see here that the cumulative survival is lower for those with type 2 diabetes with a hazard ratio of 2. And youth with type 2 diabetes also have, unfortunately, a high rate of early complications. So shown here is data from a pediatric clinical trial called the TODAY study. The TODAY original study was a medication trial for type 2 diabetes, but TODAY also had long-term follow-up data. So they followed roughly 500 adolescents with type 2 diabetes for 10 plus years. So at the time of this data, the mean age of the participants was 26.4 years, so young adults, and the mean time from diagnosis of diabetes was just 13.3 years. So you can see here that at baseline, many of the participants started off with some complications, including hypertension, kidney disease, dyslipidemia, or nerve disease, but the rate of the incidence of these complications progressively increased throughout the course of the study. And by at least 10 years of follow-up or 10 years of diabetes diagnosis, more than half of the cohort had at least one complication, and many of these adolescents and young adults had two complications. When they looked at just any microvascular disease, so this would be retinal, kidney, or nerve disease, at baseline, the prevalence was 9%, but the cumulative incidence over the course of the study increased to 80%. The goal of diabetes care is to prevent microvascular and macrovascular disease. And so when you look at macrovascular disease in the cohort, there were 17 cardiovascular events, and there were overall 6 deaths in this very young cohort of adolescents and young adults. So definitely a very aggressive form of the disease. So a question that probably comes to mind is, why is this the case? What are the differences between youth and adult onset diabetes that cause these children to get diabetes early and for the disease itself to be aggressive? I think to begin to understand these differences, we have to start by looking at the risk factors for type 2 diabetes in children. So type 2 diabetes is caused by a complex interplay between genetics, environmental, and social factors, and an interaction between multiple of these factors in different ways. So when we look at individual risk factors, obesity is by and large the single largest risk factor for the development of type 2 diabetes in children, and probably the reason why we're seeing such high rates of pediatric type 2 diabetes in recent years. But obesity is definitely not the only reason why an individual is at risk for diabetes. So genetic predisposition definitely plays a role. Race and ethnicity. So being a youth of color puts you at a higher risk for developing type 2 diabetes compared to if you are white. Family history of type 2 diabetes, especially in your immediate family members, is a significant risk factor for the development of diabetes. Maternal gestational diabetes is a significant risk factor, not only for the mother, but also for the offspring to develop type 2 diabetes. And then female sex. So this is something that is unique to pediatrics and not observed in the adult populations, but girls more than boys are at higher risk for developing type 2 diabetes. The reasons are not entirely clear, but it's thought to be maybe related to the earlier onset of puberty in girls compared to boys. And then puberty itself, I think, is a very unique phenomenon that predisposes children to type 2 diabetes. So puberty in all children, regardless of whether they go on to develop diabetes or not, is associated with a transient decrease in insulin sensitivity or increase in insulin resistance, secondary to the effects of hormones such as growth hormone. And so this is thought to be the tipping point for the development of diabetes. So it is not impossible, but rare to see prepubertal children develop type 2 diabetes. And puberty is oftentimes the time when youth are diagnosed with type 2 diabetes. So in terms of pathophysiology, there are distinct differences between the pathophysiology of pediatric and adult onset type 2 diabetes. So shown here is first a figure showing the relationship between insulin sensitivity and insulin release. So the relationship between insulin sensitivity, so insulin sensitivity and insulin resistance are the inverse of each other. So the relationship between insulin sensitivity and insulin release or beta cell function is not linear, and it's thought to be more of a hyperbolic relationship. So if there are instances when there is a decrease in insulin sensitivity, say during puberty or a short-term course of glucocorticoids, it is usually the body is able to compensate with an increase in insulin secretion. So you see here, so even if the insulin sensitivity goes down, as long as there is a compensatory increase in insulin release, the body is able to maintain blood glucose levels in the normal range. However, when this insulin secretion is no longer able to keep up with the degree of insulin resistance, that's when first impaired glucose tolerance develops. And then ultimately, when the insulin secretion can no longer keep up with the high degree of insulin resistance, that's when type 2 diabetes develops. So this is sort of the framework for the relationship between insulin sensitivity and insulin release. So when we compare children and adults, there are some key differences that emerge. So this is data from a study called the RISE study, where they compared both youth and adults with early onset and prediabetes, and they did hyperglycemic clamps to compare the physiology between these two groups. So shown here is data on insulin resistance, which is shown is the hyperglycemic clamp data shown on the y-axis, and you can see that for any what RISE found was that for any degree of adiposity, so it really didn't matter what the degree of adiposity or obesity was, that youth had a greater insulin resistance compared to adults. And when they looked at insulin secretion, again with hyperglycemic clamp data, they found that youth had a greater degree of insulin secretion for any degree of insulin resistance compared to adults. So the adults are shown in blue and the youth are shown in red, and that you can see for any degree of insulin resistance here shown on the x-axis, youth have a greater degree of beta cell secretion shown on the y-axis. And it is this beta cell hyperresponsiveness that is thought to be leading to early beta cell burnout and an aggressive disease course in youth compared to adults. So this is sort of one of the key pathophysiological differences between pediatric and adult onset form of the disease. One thing that is very important to note is that youth with type 2 diabetes come from homes with challenging social and economic circumstances, and these are definite risk factors in combination with biological and genetic risk factors that increase their risk for diabetes as well as their risk of diabetes progression. So this is data from the TODAY study, which is the study that I mentioned, a clinical trial for type 2 diabetes. And I like to show their table 1 because I think that it is very representative of the youth onset type 2 diabetes demographics. And over the years, multiple studies have shown that the demographics are the same. So these are children who are average, they are late pubertal or post-pubertal children. So on average, 14 years old, all obese, predominantly female, mostly youth of color, so very high numbers in terms of family history of type 2 diabetes, and roughly 1/3 of the TODAY cohort had gestational diabetes. But I want you to sort of pay attention to this right side of this slide, which shows you some more about their social and economic circumstances. So in the TODAY study cohort, only 38.7% of the participants lived with both parents. And there was close to 10% of these participants lived with neither their mother nor father. Only in terms of parental education, significantly high numbers with a less than 12th grade or only a high school education. And then annual income numbers also show that these children come from families with a great deal of poverty. So to summarize this first part of the talk on the background for pediatric type 2 diabetes, youth onset type 2 diabetes is on the rise and disproportionately affects youth of color. Youth with type 2 diabetes have an aggressive disease course and a high risk of early complications that is worse than adults with type 2 diabetes, as well as youth with type 1 diabetes. There are key pathophysiological differences between youth and adult onset diabetes. Youth have a greater degree of insulin resistance for any degree of adiposity compared to adults. And youth have greater insulin secretion for any degree of insulin resistance. And it is this beta cell hyperresponsiveness that is thought to contribute to the difference in pathophysiology between youth and adults. And very importantly, youth with type 2 diabetes come from families that are challenged by poverty, poor education, and widespread poor health. So with that knowledge, I want to move on to the second part of my talk, which is on the genetics of type 2 diabetes in youth. So it has been known for a very long time that clinical risk for diabetes is accelerated by heritable factors. So why not, if most youth with type 2 diabetes are obese, why not just study obesity? So what is the importance of studying genetics for type 2 diabetes? And I think this is illustrated well in this study. This is a very old but classic study that I think illustrates the point very well. So this is a study among Pima Indians with obesity. And they found that among those individuals who had one parent with diabetes had a twofold higher risk of developing diabetes. And if individuals with two parents with diabetes had a fourfold higher risk of developing diabetes. So I think this nicely shows the interaction between the environment and the accelerating capacity of genetics. So overall, type 2 diabetes is caused by environmental factors and behavioral factors that lead to obesity, but this is overlaid on a background of genetic predisposition because not all children with obesity will go on to develop diabetes. And so this is a really important point. And I think it's also just, as the clinician in me always likes to mention this to my families that I'm talking to when there's a child with a new onset diabetes, because I think there's so much blame and guilt and shame associated with the new onset type 2 diabetes diagnosis. So I think it's important to also tell our families that this is not their fault, and there's so many risk factors, and it's a combination of these risk factors that cause a child to develop diabetes. And type 2 diabetes, since then, we now know that type 2 diabetes is a heritable syndrome, but it is also a very heterogeneous syndrome. And so the evidence for heritability comes from in multiple ways. There have been early twin studies that show that concordance for type 2 diabetes risk is greater in monozygotic versus dizygotic twins. We know that the incidence is much higher in certain racial and ethnic groups. This can also be related to different environmental and social risk factors, but even when you account for these differences, the incidence is much higher in certain racial and ethnic groups. Family history is an independent risk factor for the development of diabetes. And then there are examples from monogenic causes of diabetes, so either from MODY or from single gene diabetes disorders. We know that just a single gene mutation, which can cause protein changes, are sufficient to cause hyperglycemia. So there is all this points towards the evidence for diabetes heritability. And indeed, over the last a decade, there has been so much knowledge gained on the genetics of type 2 diabetes in adults. So right now, in the adult diabetes genetics world, there have been over 700 genetic variants that have been identified to be associated with diabetes in adults. If you quantify the heritability of type 2 diabetes, it is roughly thought to be in the 30 to 40% range. And we think that right now, all the genetic discovery together probably explains about 50% of this heritability. However, the genetic basis of youth onset type 2 diabetes remains largely unexplored. So we know that there are phenotypic or clinical differences between pediatric and adult onset diabetes, but until recently, we knew very little about the genetics of type 2 diabetes in children. So I had the good fortune of being, when I was a fellow in pediatric endocrinology, to be involved in the inception of this consortium called the ProDIGY consortium, and I continue to be involved in this consortium and now lead it. but this is a consortium that was developed to study pediatric type 2 diabetes genetics and genetics of related traits. And it is a consortium of 3 different study groups. So the Today study, which I mentioned, Search for Diabetes in Youth, as well as T2D Genes, which is an established adult diabetes genetics consortium. So in terms of the data, today, like I said, is a clinical trial. There were 699 participants in the original trial, and today also conducted an ancillary genetic study where there were over 2,000 youth. Search for Diabetes in Youth, which is an observational cohort with 449 youth with type 2 diabetes. And then adult T2D Genes is an adult genetics consortium where they have access to tens and thousands of cases and genetic information related to cases and controls. Putting all this together, we now have over 3,000 cases of pediatric type 2 diabetes, and all of these individuals have genome-wide genotyping as well as whole exome data. So at the onset, when we were starting off this consortium, we wanted to sort of, lay the framework of, what exactly our goal was, knowing that there's so much had been done in the adult diabetes genetics world. So first off, I just wanted to sort of orient everyone to the genetic architecture of type 2 diabetes. So genetic architecture of type 2 diabetes is thought to be a combination of both common and rare variants. So common rare variants are occur commonly in the population and are thought to have small effect sizes, and these are typically picked up on genome-wide association studies. Rare variants, so very rare variants with high effect sizes, are typically single gene disorders that cause what we call traditional Mendelian diseases or monogenic diseases. We also think that there are certain variants that are lower frequency, not as common as the common variants, but more low frequency variants that have an intermediate effect that also influence common disease, such as type 2 diabetes. So our hypothesis at the outset for this consortium was that youth onset type 2 diabetes risk variants may impact the same genes and pathways involved in adult onset diabetes, but may have larger effect sizes or an increased polygenic burden of variants to explain the earlier onset and the more aggressive form of disease. And then our second hypothesis was that some risk variants may lie in genes or pathways that are unique to youth onset type 2 diabetes. So in ProDIGY, first we did common variant analysis and we conducted a GWAS for type 2 diabetes in youth. So shown here are the baseline characteristics of the participants. So in total, we had 3,006 youth cases, as well as 6,000. We chose 6,000 matched adult controls. And then we also had a small subgroup of youth controls without diabetes. The adult controls were selected to be greater than 50 years and without diabetes. And the reason for that was that you kind of can never, when there's an adult, it's very hard to know whether they will ultimately develop diabetes or not, which is why we wanted to choose a slightly higher age range than just all adults. The mean age of our youth cases was 15 years compared to 54 years for the adult controls. And similar to what I presented before, the majority of the youth cases were female. The majority of the youth cases were youth of color. We only had access for the genetic analysis. We only utilized the African American and Hispanic or Latinx cases. There were a small number of Asian and Pacific Islander cases, but they were too small to do genetic analysis. And then the Native American subgroups in the ProDIGY consortium declined participation in the genetic analysis. The mean BMI Z-score, so all of these cases, youth cases, were overweight or obese, as you can see here, and they had a high fasting glucose and an average A1C of 6.75%. So in our genome-wide association study, so we're looking at associations of genetic variants across the entire genome, we identified 7 genome-wide significant variants associated with type 2 diabetes in youth. So this is a Manhattan plot, and on the x-axis, you see the various chromosomal coordinates. On the y-axis is the negative log p-value. So the higher on the y-axis, the lower the p-value, and then you see this black line that indicates the genome-wide significant threshold of 5 times 10 to the power minus 8. And the reason for the high threshold is because we are performing so many association testings. And so that is the Bonferroni correction to account for that. And so these are the variants that we identified. And here they are listed. We identified a novel variant that had not been identified before in adults in the gene PHF2, as well as variants that have already been associated with adults. So TCF7L2 is a very well-known type 2 diabetes locus. MC4R, again, is an obesity locus. And then all the remaining variants were also previously identified in adults. So our next question is, what about, so those were individual variants, but what about polygenic risk variants? So like I said, most of the common variants, there's are hundreds of variants, and each variant only has a very small effect size. So no single variant on its own contributes to disease risk, and every single variant has a very small effect size that come together to cause an aggregate genetic risk burden. So we wanted to look at the polygenic risk burden. So we constructed polygenic risk scores, or genetic risk scores, with 303 published adult type 2 variants at the time. So there are now more published variants, but at the time we used 303 adult variants, and we constructed polygenic risk scores. And we compared the association of these risk scores between youth cases, youth control, adult controls, as well as adult cases, adult controls, and youth cases and youth controls. And what we found that the odds ratios were highest in the analysis that included the youth cases versus the adult controls compared to the adult only or the youth only analysis, again, showing that the aggregate genetic risk burden is higher in youth with diabetes compared to adults. So what I showed up until now is the common variant analysis, but we also have access to whole exome data and ProDIGY. So the question was, what is the contribution of rare variants, or what is the contribution of coding variants to type 2 diabetes in youth? So we started off with, we had whole exome data on 3,333 of our ProDIGY participants. And then we selected, we had data from T2D genes on 24,000 adult controls. We did joint variant calling and ancestry matching by PC clustering and sort of standardized quality control metrics. And at the end, we had, after filtering out, we had 3,005 youth cases, as well as 9,777 matched adult controls. And we did both single variant association, sort of similar to the GWAS, as well as gene level, individual gene level burden tests. And in our single variant association, we identified 2 variants that were significant, including variants in SLC16A13, as well as a variant in TGF beta 1. And TGF beta 1, interestingly, was significant only in the African American youth. And then if we use a slightly more lenient exome-wide significant threshold, then we additionally had variants in WFS1 and SLC30A8 that were also significant. You can also see that the variants that are highlighted here also came up in the common variant analysis. And then when we did the single gene level burden test, we found that variants in HNF1 alpha and MC4R were significantly associated with youth onset diabetes with pretty high odds ratios, as you can see here. So the next step was to answer our question about genetic risk for children compared to genetic risk for adults, looking at both common and rare variants. So what you're looking at here is the liability variants, or the genetic variants explained by both the common and rare variants for first youth onset diabetes as well as adult onset diabetes. And we did this in multiple ways. We first looked at only the exome-wide significant variants. We looked at the top 10, top 25, as well as all of the known type 2 diabetes genes. And in all instances, for both the common variants and the rare variants, the youth onset diabetes variants explained more of the genetic variants in children compared to that in adults. And this was greater for rare variants compared to common variants. Again, showing overall that the genetic overlap for pediatric type 2 diabetes significantly overlaps with the genetics of type 2 diabetes in adults, but the aggregate genetic burden for children is larger when compared to adults. And then we also looked at monogenic diabetes in ProDIGY. So monogenic diabetes can sometimes be, or in all times be very difficult to ascertain clinically, because monogenic diabetes will also present as an autoimmune negative diabetes. And so we looked at the numbers of cases of monogenic diabetes in children who are with a clinical diagnosis of type 2 diabetes in ProDIGY. So we did, again, whole exome sequence data in 3,333 participants with type 2 diabetes. And we found that 93 or 2.8% of these individuals carried a likely pathogenic or pathogenic variant in known MODY genes, including HNF4 alpha, GCK, HNF1 alpha, PDX1, insulin, and CL. We also looked at the clinical differences between those who had MODY and those who had type 2 diabetes. And we specifically also looked at clinical differences between those who had GCK or glucokinase MODY, which is MODY2, and other forms of MODY. So glucokinase MODY is sort of the best kind of MODY to have, because this individuals with GCK MODY do not require any treatment. So they just have a slightly higher glucose values, but they do not require treatment, and their risk of complications is also low. So what we found was that MODY youth had a younger age of diagnosis compared to those with diabetes, as you can see here. And this was, again, driven by the GCK MODY. They also had a lower fasting C-peptide levels, were less likely to have hypertension, and were also had higher HDL levels compared to those who had type 2 diabetes. So summarizing the genetics part of my talk, through GWAS, we discovered 7 common variants associated with type 2 diabetes in youth, both novel and known. The novel variant was discovered in PHF2. Through exome analysis, we found exome-wide significant common coding variant associations in WFS1 and SLC30A8, and then exome-wide significant rare variant gene level associations in HNF1 alpha, MC4R, and ATX2 and L. Many association signals were shared between youth and adults. However, there were larger effect sizes for youth onset type 2 diabetes. And then both common and rare variant associations contributed more to youth onset type 2 diabetes heritability than they did to adult onset type 2 diabetes. And lastly, less than 3% of youth with a clinical diagnosis of type 2 diabetes may have monogenic diabetes. So it's very important to keep that in mind when we are seeing patients clinically, because a lot of times in MODY, we are able to offer a different treatment. So it's important to screen for MODY when appropriate. So in terms of where we go from here, I think this is just the beginning of genetic exploration for pediatric type 2 diabetes. I think next steps will include functional characterization of some of our associations, as well as looking at whether any of these polygenic risk scores are able to predict both disease progression or treatment response. So much more to do for pediatric type 2 diabetes genetics. So moving on to the third and final part of my talk on metformin response in youth with type 2 diabetes. So metformin is the foundation of diabetes treatment, both in adults and children. So this is the treatment algorithm for type 2 diabetes. And there are now over a dozen classes of type 2 diabetes medications. And metformin, despite this, metformin remains the first-line therapy and the foundation of diabetes treatment. And any medication is usually added on in addition to metformin. So it's the foundation of diabetes treatment, likely because it is cheap, well-tolerated, effective, and is thought to have benefits that extend beyond just glycemia. So it's been shown to have cardiovascular benefit, and metformin also has been shown to have non-diabetes related benefits. And again, in children as well, metformin is our first-line therapy. And in children, metformin is the only FDA-approved oral medication. So currently in children, there are only metformin, insulin, and GLP-1 analogs are approved for the treatment of type 2 diabetes, and metformin still remains our only first-line treatment for the management of diabetes. And again, the foundation of diabetes treatment in children. However, there is a substantial variability in how children or youth respond to metformin. So this is data from the Today study, where 699 youth with type 2 diabetes were randomized to 3 treatment arms: metformin only, metformin plus rosiglitazone, which is another drug class, as well as metformin plus an intensive lifestyle intervention. And the primary outcome of this study was either the need for addition of insulin or a hemoglobin A1C of greater than 8% for 6 months. So the results of the Today study showed that overall there's a high failure rate for metformin treatment in all study arms, and that there was a small but significant improvement with rosiglitazone. But metformin, there was no significant difference with the addition of lifestyle intervention. So metformin plus lifestyle intervention did no better than metformin alone. And I think one of the most important take-home points from the Today study is that close to 50% of the youth had glycemic failure on metformin over the study period of just 4 years. And then when we compare this with adults, youth also have a high, worse metformin response compared to adults. So this is not head-to-head comparison, but a figure that shows a comparison of the results from various studies. So the gray bars are the Today study, and then the remaining 3 bars represent different adult studies. So the ADOPT trial, this is data from the US Department of Defense, and then UKPDS, which is again an adult classic adult diabetes, type 2 diabetes study. And so for metformin, failure rates are higher in Today, compared to adults. Metformin plus rosiglitazone failure rates were higher. Children had less improvement in insulin sensitivity, as well as a greater decline in beta cell function compared to adults. So the question is, why is it that children do not respond as well to metformin? And there could be many potential reasons, and I've sort of listed some reasons that children can have a differential metformin response compared to adults. So the first one is that there could be differences in just the underlying disease. We know there are differences in pathophysiology, so this could be causing differences as well as clinical features. So the Today study did look at this when they evaluated metformin response. So they compared those who, quote unquote, failed metformin therapy, so 120 kids, and compared those with all the youth that did not fail metformin therapy over the course of the study. So they were roughly, like I said, half and half. And they found that hemoglobin A1C at baseline was one of the strongest predictors of metformin response. So the children in the Today study had a run-in period. And after the run-in period, those who were able to maintain a hemoglobin A1C that was less than 6% were more likely to be able to have sustained glycemic response to metformin. So the lower the A1C at baseline, the lower the A1C during the course of the trial. So it seems a little bit intuitive, but it's also a little bit alarming to know that the A1C required for glycemic for sustained glycemic response is not closer to 7%, which is what the ADA recommends as a treatment target, but closer to less than 6%. Another distinguishing factor between those who responded to metformin and those who didn't were beta cell function. So there were no changes in insulin sensitivity or insulin resistance between those children who failed metformin therapy versus those who didn't. But the participants who had sustained glycemic response to metformin had a better beta cell function, or which was measured as the insulinogenic index, compared to those who failed metformin therapy. So those who failed are shown in the red compared to those who didn't in the blue. And you can see right off the bat that the beta cell function is lower in those who failed. So moving on to other differences. So renal function. So metformin is a drug that is renally cleared, and therefore any alterations in renal function can lead to differences in metformin response. And this is definitely something that plays out in adults and older adults where the prevalence of kidney disease is high. In children, so far, this hasn't been found to be a significant risk factor because thankfully most children with diabetes have normal renal function, and there isn't a great degree of variability in renal function among children unless they have other concurrent diseases. And so renal function is definitely an important determinant, but specifically may not play a huge role when we're comparing children to adults. Moving on to the next part, so genetic burden. So there is a genetic basis to response to metformin. So the studies have estimated that the heritability estimate for metformin is about 20 to 30%. And this is an estimate comparable to other complex phenotypes. And indeed, studies in adults have identified genetic variants that are associated with metformin response. So the first variant that was identified to be associated with metformin response was ATM. Again, work here done at UCSF found in the Giacometti lab found that SLC2A2, which encodes a glucose transporter, is associated with metformin response, and subsequently further variants have been identified to be associated with metformin response, including work that I was involved in the diabetes prevention program, where we showed that variants in OSF1 and OSMR are associated with metformin response in at-risk adults. So what does this look like clinically? There all these variants, we're saying that they're associated with metformin response, but what does that mean clinically? So this is work that was done as part of a cohort called SUGAR-MGH, or the study to understand the genetics of the acute response to glipizide and metformin in humans. And in SUGAR-MGH, we had data on 700 adults who are at risk for diabetes, and they received 4 courses of metformin. And we measured we did OGTTs at baseline and 4 days later. And we found, we examined the effect of genetic variation in TCF7L2. So TCF7L2 is one of the strongest common variant risk factors for type 2 diabetes. And we found that those who had who were homozygous for the high risk allele at RS7903146 in TCF7L2 had a better response to metformin compared to those who were either heterozygous or wild type for this variant. And it translated to about a change in glucose of about 1.6 points. And so definitely all of these, there is a clinical translation and a clinical implication for all of these genetic findings. So with all of that data in adults, our goal was to then look at this in children. So again, in the ProDIGY consortium, we looked at the genetics of metformin response through a genome-wide association study. Even though we had data on over 3,000 youth participants, we were only able to quantify metformin response in the clinical trial participants. So 500 kids with diabetes, mean age of about 14 years, majority female, majority youth of color, again, mostly obese, and they had an average post-randomization hemoglobin A1C of 6%. In ProDIGY, we did a genome-wide association study, and we did not identify any genome-wide significant variants. And we think this is likely because our sample size was quite modest compared to genome-wide association studies, particularly in adults where there are tens and thousands of subjects. So we then chose to replicate our top findings in 3 cohorts. So we replicated our findings in the Metformin Genetics Consortium, in the Diabetes Prevention Program, and in SUGAR-MGH. And we found that RS7619522 in ATR and L1 was associated with worse metformin response in adults in the Metformin Genetics Consortium, and individuals who are homozygous for this variant in the Metformin Genetics Consortium had about roughly 0.5 higher hemoglobin A1C on metformin compared to those who had the wild type allele.
And then lastly, moving on to pharmacokinetics. So pharmacokinetics, or how much of a drug level you achieve when given a medication, definitely plays a role in drug response. And so we wanted to also explore this element related to metformin non-response. So just very briefly, some basics on metformin pharmacokinetics. So metformin is excreted unchanged in the urine. It's renally cleared. It has a half-life of about 5 hours, and the population mean renal clearance in adults is about 510 mils per minute. And so metformin is taken up into the intestine by metformin transporters PMAT, encoded by SLC29A4, as well as OCT3, encoded by SLC22A3. It is taken up by the liver primarily by OCT1 and OCT3. And then renal excretion of metformin is mainly encoded by, again, metformin transporters, MATE1 and MATE2K. And I think it's just it's an interesting and really nice historical fact that a large part of the work related to metformin PK and metformin transporters was done right here at UCSF in the School of Pharmacy. So in terms of metformin PK or pharmacokinetics, specifically in youth with diabetes, so the data is very limited, and a large part of our knowledge on metformin PK comes to us from data in adults. There was a small study on 32 subjects of ages 12 to 16 years without diabetes, in which children were on 500 milligrams twice daily of metformin. And metformin area under the curve was only about half of that reported in adults with the same dosing. And other smaller studies have reported similar PK parameters. So it is not clear what the influence of age, diabetes, or obesity has on metformin pharmacokinetics in youth, and whether this can be a potential reason why children have differential response to metformin compared to adults. So we chose to explore this aspect of metformin pharmacokinetics through a study titled POP-PK Kids. So a population PK model for metformin in youth with type 2 diabetes. So population PK modeling is a method in which you can provide estimates of PK parameters in a specific population by identifying sources of variability or covariates using sparse or limited PK data, and then quantifying the impact of each covariate using a nonlinear mixed effects model. So this is a study that doing here at UCSF. Unfortunately, we do not have final results yet to show you, but we just finished recruitment for this study. So I wanted to share some of our just baseline data. So this is the study design. So we are enrolling participants with type 2 diabetes, requesting a 3-day medication log. So it's important that the participants are actually on metformin. And so we ask about metformin use, and also ask that they document a 3-day diary to know when they took their metformin in the 3 days preceding, leading up to the study visit. On the day of the study visit, there's 2 ways in which the study visit happens, either through the Pediatric Clinical Research Center at UCSF or through home visits. They have their height, weight, and serum creatinine measured. We do sparse PK sampling, so 3 time points, baseline 1 to 2 hours, and then 4 to 6 hours post-dose, and then use that data to then develop the population PK model. So we just recently completed enrollment for this study. So shown here are the baseline demographics of the participants. So the mean age is 15 years. I'm a little surprised about the proportion of female participants in our particular study, because it's not consistent with the sort of studies that we've seen so far. But in our study, only 35% of the participants were female. 70%. So the majority were not Latinx, and you can see that we had a diverse representation from other racial subgroups as well, I think highlighting the diversity of our UCSF population. And these we recruited both from San Francisco as well as Oakland. Well, like I said, we haven't developed a population PK model yet, but we did some interim analysis, and I wanted to share some of that data. So this is work that is led by Kevin Yen, who is a third-year pediatric endocrine fellow in our division and a soon-to-be new faculty member. And so we measured metformin trough levels in the first 20 of our participants. And what we discovered was that 5 out of the 20 participants, or 25% of our participants, had a metformin trough level of 0. So that means that they had no metformin level in their blood. And this was after sort of screening both the parent and the child to make sure that they're taking metformin after requesting that they complete a 3-day medication diary. We were a little bit surprised to find that a good subset of our participants were not taking metformin at all. We also collected data on metformin adverse effects, and we found that a substantial proportion of these kids reported that they had some form of side effects, despite not reporting this clinically to their provider. And so our next steps are to use this data now to develop a population PK model. And then our next step following that is that if we do find that there are covariates or there are factors that influence metformin PK in youth, then to develop a precision dosing algorithm for metformin. Our overall assumption is that youth with may be able to tolerate higher doses of metformin compared to adults. And so we hope to test this in a pilot study in the future where we give youth with diabetes higher doses of metformin according to this precision dosing algorithm and compare it to standard care. So hopefully I will be able to provide updates on this in the future. So to summarize the last part of my talk, metformin remains first-line therapy for diabetes. However, there is significant variability in response among youth, as well as when you compare youth with adults. Response to metformin is heritable. To do pediatric genetics, we definitely need larger sample sizes in order to be able to elucidate the genetic factors that are related to metformin response. There may be differences in the pharmacokinetics of metformin in youth with type 2 diabetes compared to other populations. And then in our own small study, we did find that metformin adherence itself may be low in youth with diabetes, and that if the frequency of side effects may play a role. With that was, then I wanted to thank all various people who have supported me in my research. First, the Progress in Diabetes Genetics and Youth Collaboration, and Jose Flores, who was my mentor when I did fellowship and continues to mentor me, Phil Zeitler, Donna Dabalia, as well as the Today Search and T2D study groups. My mentors, Kathy Giacometti and Radha Savic in the School of Pharmacy, as well as Steve Gittleman in the Division of Pediatric Endocrinology, my entire UCSF Pediatric Endocrine Division colleagues and fellows, Laura Dapkus and Emilio Fernandez were the clinical research coordinators for PopPK Kids, and then Kevin Yen, Pediatric Endocrine Fellow, who is helping lead this work, as well as my chief, Maya Lodish, for all of her support. And then all my funding sources through the Pediatric Endocrine Society, pilot funding through the Diabetes Research Center, as well as an NIDDK K23. So yeah, thank you all so much, and I'm happy to take questions.
Thank you, Shy. That was wonderful, a real tour de force. And I think you mentioned that you had completed enrollment for your K23 project. So congratulations on that. That's fantastic.
Thank you.
Naomi put in the chat that she might have someone she could refer, but it sounds like maybe for the next go around.
Right. I'm usually so thrilled when I see messages like that, but I'm now
I know we're
excited to state that I've closed. It was
looking at your data.
It was a COVID enrollment study, so there were definitely numerous challenges. So we're very excited to have completed.
Yeah, congratulations. It sounds like Marissa has a question, and then Jackie. So I'm going to go ahead, Marissa.
Yeah, thanks so much for a fantastic talk. You really did present a lot, and so that was incredible. Actually, 2 questions for you about your genetics. So the first is, I was pretty surprised to see that you actually found a genome-wide hit in your youth study that has not been previously found in the adults. And I wanted your thoughts on, the adult populations. Those genetic consortiums are very large now. And so do you think that, is there just absolutely no signal in the already published GWASs, or do you think that there is really something specific about that locus for youth type 2 diabetes?
Yeah, that is an excellent question, and a question that we thought a lot about. So you're right. So the adults diabetes GWASs are now, I guess, hundreds of thousands of adults. And so when we look through all of the public resources, this particular variant is not associated with type 2 diabetes. It is associated with height and therefore BMI. But we did do some conditional analysis to ensure that our signal was independent of BMI, and we still found there was a signal even when you accounted for BMI. I think it's hard this is just an association signal. So we definitely think there are differences. Even the ones that we did identify that were also associated in adults, our effect sizes are almost across the board larger in pediatrics compared to adults. So one thing is the effect size. I think we need to follow up with some more functional work before we can answer that. I think PHF2 is broadly related to adipogenesis, and there are some mouse models that show that mutations in PHF2 can lead to hepatic steatosis. But at this point, I acknowledge that this is association study data, and we definitely need to do more functional follow-up to be able to characterize why that particular variant came up as a hit. But we did do but one thing we were sure of is that it is a true association signal and not noise, because that was the exact question that we had and reviewers had. And I think we were able to nail down that this was actually a true signal.
Yeah, and thank you. My second question is that so you had mentioned
I'll
that
stop share so I can see you. Okay, there.
Oh, yeah. In the youth, it sounds like it's more of hepatic insulin resistance, right? And have you thought about using the partitioned PRSs from the CHARGE consortium to look more closely at, are you really seeing more genetic signal in sort of the liver lipid axis versus the other the other molecular pathways that lead to diabetes?
I'm only smiling because that is literally my grant that I put in, right? I think that is a fantastic idea, which is what I hope the reviewers think as well. But I think, yeah, you're right. In adults, I think it's important. I think the two important questions are, what is the contribution of these individual groups of genetic variants? And then the second thing is this different when you compare adults versus kids? And so, yes, I'm definitely looking at that. I did some preliminary analysis in ProDIGY, but again, our sample sizes are pretty small, so we weren't able to do much. But I'm actually working with Miriam Adler, who did some of the CHARGE analysis to try to do this in children. And I think that's sort of the next phase of genetic discovery, is just not doing broader GWASs, but sort of trying to pinpoint mechanistic pathways. Thank you for the
Excellent.
Yeah.
Thank you so much.
So Naomi says congratulations. Jackie Gretfeld, she actually had to drop off, but she had asked a question about whether or not you've looked into GLP-1 agonists in these kids. So
yeah, it's a great question. I think it's our newest, latest and greatest, and we're using it extensively. It's just that we don't have any data on any genetic data related to GLP-1. There's some data coming out in adults, but there's literally no pediatric data on genetic data on GLP-1 agonists. But that's, again, I think the goal of genetics when it comes to pharmacology is ultimately, are we going to be able to identify responders and non-responders, or be able to optimize therapy based on genetics? And I think we aren't there yet. But GLP-1s will be a really important drug class if we do get to that point, because we prescribe it all the time.
All right, I know we're at time, so does anyone else have any other questions they want to unmute and ask? Thanks everyone for sticking around, and again, thank you, Shy, for a great talk.
Thank you. Thanks everyone.
Learned a lot.
Thank you, Roberta. Bye.
Right.
Take care.
Bye.